would like to invite Dr. Arvind Sharma sir for the next session on clinical indicators in stroke management. He is head Department of Neurology and Stroke Specialist, Zydus Hospital, Ahmedabad, Assistant Professor Neurology, NHL Medical College and SVP Hospital, Ahmedabad, Secretary, Indian Stroke Association and Board of Director, World Stroke Organization, Vice President, Society of Neurosomnology and Director, Brain Heart Foundation. So over to you, sir.
Thank you for the introduction. Thank you very much. And I would like to thank Kao for the invitation, and I thank even the Indian Stroke Association, and I can see Dr. Nirmal Surya, our president-elect, and Dr. Kumar Velu here. I really thank for this session to Kao for creating the awareness about stroke. We are definitely, we were supposed to do on the World Stroke Day, and we got slightly delay because of some technical reasons. So I'll try to load my presentation. Just you have to let me know that you are able to see that or not. Is it?
Yes, it's visible.
It is visible. Right. So because of some technical reasons, I was not able to join, but thank you very much. And I missed few of the presentations here. And you all may able to see the presentation, and I'm audible, right? Yeah, I'm audible?
Yes.
Yeah, thank you. So before we move towards the clinical indicators in stroke management, definitely what just been said by the chair of the panelist was absolutely correct. That is, stroke is not a magic bullet done by one like a cardiologist to open the artery. We need a team, and for developing a team, you need to have that networking with you, which we have developed during this time with Indian Stroke Association. So it's a teamwork. It's not an individual work, where from the acute care, you go up to the patient getting discharged for rehabilitation. So it is a comprehensive treatment for the stroke, and you need the clinical parameters, the clinical indicators to treat those stroke management to be uniform across India, or even you want that at the Indian Stroke Association level or the World Stroke Association level, you want that the standard of care, the clinical indicators for stroke remains same. So in view of that, to develop those standards, the Indian Stroke Association took initiative in 2022, and Indian Stroke Association was formed in 2002. This is just the background. I may repeat, I have not seen the previous presentation, but I would like to emphasize on this that ISA has worked for the standardization and for the accreditation program from 2022. This is what we developed as a MOU with the QAI before I go for the clinical indicators in July 2022, and where we were coming out of the COVID, and definitely we developed this program. And we have the stroke standards. They are there on the website. You can ask, you can purchase, and you can go through those accreditation, and even you can apply for the primary and the advanced stroke centers. I think Dr. Rana is going to talk about those standards. But I'm here to talk about more about the clinical indicators in stroke management, but they are there in this book. You can go through it. So for any continuous quality improvement or to develop a standard, the most important is the safety of the patient, which is paramount. And how you develop that quality and how you develop that improvement for the patient care and identify and prepare a plan, there you need some indicators which are very important to develop and improve the quality and safety of the services. So you have to do a regular evaluation. You have to develop performance indicators and the benchmark, which has to be revisited every few years and has to be standardized across the nation in the similar manner. So the positive outcomes and the area of improvement can be seen, and those can be taken as a benchmark for applying any services. It is, we are talking about stroke, but it implies for any disease. And this is, we are proud to say, this is the first disease specific quality indicators we are developing. Few example for that in acute stroke, which we look upon, because in acute stroke, the time is brain. It is very important that we know that how we will give the best treatment to the patient and the patient outcome will be best, and how we can do it. So few of the indicators like patient in the acute care, when the patient comes to the door of any hospital, is it a primary center or the advanced center? And I think emphasis may have been given that a minimum of CT scan is required to diagnose a stroke, because there are ischemic and there are hemorrhagic stroke. So CT scan is equivalent to the ECG for cardiologists for us. So this is what we mean by the door, that the patient reaches to the door of the hospital where the stroke services are given. So the one of the clinical indicators in stroke is door to physician time, is that is ER physician less than equal to 10 minutes. We know the golden window for treating any acute stroke is within 4.5 hours. And for the interventions, it goes to 6 to 9 hours. We want that if you have a stroke team, door to stroke team less than equal to 15 minutes. Door to CT or MR initiation is less than equal to 20 minutes. Door to CT MRI interpretation less than equal to 30 minutes. This is how you come to those minutes. This is not that one of the 5 people sitting in the room and develop those standards and we have put it as that we want it. It is not like this. It is, you see across the world, when we see that any patient come to your door should be treated within 60 minutes, which is the World Stroke Organization and even the Indian Stroke Association guidelines, and the guidelines which is developed by the neurologist and the stroke neurologist, that within 60 minutes, the patient should get the treatment in the form of thrombolysis, which is the clot buster drug. So how you can do it, right? You just can't get the patient in directly shift to the CT scan. You need door to physician time of less than 10 minutes to identify the symptoms. It may be a stroke mimic. So stroke is, the neurological symptoms are very varied. For heart, it is only chest pain, right? For brain, there are a lot of things for the localization. One side weakness, there is a deviation of the mouth. You all know about the symptoms of the stroke. I'm talking to the August audience who must be knowing all about the symptoms of the stroke and how to identify them. But for them to identify, you need a physician to reach on time. Once the clinical assessment is done by the stroke team, there is a indicator known as the stroke severity indicator, that is NIHSS, National Institute of Health Stroke Scale, which identify the stroke severity. And there is a scale from 0 to 42 where you know the severity of the stroke. And immediately you shift the patient to the scanning area and you took out the blood for sending to the patient to the lab. That is why the order to lab result less than equal to 30 minutes, if ordered, right? Sometimes you may not need it because you don't want to know the platelet, because thrombolytic drug may lowers the platelet more. If it is less than 1 lakh of the platelet, the patient can bleed. So that is why the lab results are important. CT, why CT oblique MRI? CT is minimum. CT are there thanks to COVID, somewhere blessing in disguise for the neurologists. Many district hospitals are having CT scan now. So there the patient goes to the CT because there are 2 types of this stroke, ischemic and hemorrhagic. We are talking here for the clinical indicator of stroke for the ischemic stroke. So less than equal to 20 minutes for the CT, and interpretation of those areas within 30 minutes. So these can be done even by the telemedicine consultant if it is a primary stroke center, because we may not have the neurologist there at the primary stroke center. So those centers where only the CT scan is available and the thrombolytic drug is there they can connect through the telemedicine to the advanced stroke center, and they are having an MOU with that, and they can get the services to treat the stroke patients. Now, further going to these standards, this is what you should have at your hospital, and which should be by the quality team should identify that they are managing this within this time frame. And if they are not, they can develop these standards subsequently by putting them on paper in their emergency and the stroke services. So further going to the indicators in stroke, how you see that you make a difference in the quality and difference in the patient's life by door to IV thrombolytic bolus greater than equal to 75% of compliance, less than equal to 60 minutes. That is door to needle time, means that is the time of bolus administration of drug within 60 minutes. So you should have at least 75% of the patient to be treated within that IV thrombolytic drug given in 75% of the patient. And door to IV thrombolytic dose greater than equal to 50%, less than equal to 45 minutes. It is not like this that it is 4.5 hours window, so you wait, oh, 4.5 hours is late. It is like this as soon as possible to your door. And it is not a single man's job. So there are a lot of people who are involved in the nursing care where the quality things are taken and subsequently administered. So if you see how by these clinical indicators, you develop the eligibility of the primary stroke centers and the advanced stroke centers, and how you subsequently see these eligibility are, you should have a structured system for the stroke care. So those centers who are treating minimum 72 patients per year, that is 6 per month, are eligible for the primary stroke center. And they should have administered IV thrombolytic of at least 6 eligible patients for the initial application year with those quality clinical indicators which we have discussed. Are in the current compliance of the statutory requirement, which is, I think QI is very good in that, and all the accreditation body are good in that. Time of application and the time of the assessment. Acute stroke team 24/7, we don't want a neurologist to be present there. We are empowering physicians to treat stroke and give the thrombolytic drug, and that is the Indian Stroke Association motive. And neurologists should be accessible 24/7 as a person or the telemedicine. And they should have the basic facilities like ECG, random blood sugar, CBC, transthoracic echo, and serum creatinine, because there are many other patients which are there. They should have a carotid. They should have the availability of the IV thrombolytic in-house. The time cannot be wasted for getting that from the outside. Designated nurse stroke coordinator, written protocol of the acute stroke triage and diagnosis, written emergency stroke treatment protocol, the neurosurgical coverage if any complication, and the telemedicine agreement for the primary stroke center. But advanced stroke center, you feel, because you are able to do the thrombectomy, you are able to take out the clot by having a cath lab at that place, which they are the advanced stroke centers. But as Indian Stroke Association initiative, we want more and more drug, more and more people to be benefited from stroke. So those clinical indicators for the primary stroke centers are very important to give that drug to the patient. And the minimum of the 6 thrombectomies and 12 thrombolysis in an initial application year. The neurologist should be 24/7. Neurointerventionist should be there 24/7, and there should be a designated neuro-intensive care unit for the complex stroke patient, and at least for the 4 stroke beds. So there should be in-house availability of the MR in the advanced stroke center. That is what the difference from the primary stroke center. There should be a facility optional for the CT perfusion, because sometimes our patient, if you ask me, patient can be treated up to 24 hours if they are at the advanced stroke center to get the benefit of the thrombectomies. So they can be taken to the cath lab. There are ultrasound available by which you can see the artery, that is the transcranial Doppler, and availability of the IV TPA altogether 24/7 to the hospital. And the rest, all the protocols are the same as the others. Thank you very much for the patient listening. I hope I have not gone out of my time.
So these these standards have been used since how long, sir?
Oh, very good question. Thank you very much. I think I'm not able to see Dr. Rana here. So
Yeah,
these,
Dr. Rana will join.
yeah,
sure.
So these standards are there from, we have started developing in July 22, December 2022. They were for the public opinion, and subsequently the first advanced stroke center which we have assessed was in March 2023. So till these standards are there from December 2022, available on the website of QI, and even on the Indian Stroke Association website, they are available. And they are being used by the assessors. First assessor program happened in Delhi. The second for these teaching for these stroke standards is going to happen in Bangalore. And we have almost has done for at least now 13 advanced stroke center assessment, and there are 3 applications for the primary stroke centers. I have not touched the standards because I saw that Dr. Rana is going to speak about the standard part. So,
Yes, he's going to
yes,
speak
sir.
about the standard.
So I have
Sir,
taken
there
only
is
the.
Dr. Suvin, even my hospital was the second hospital to be accredited.
Oh, okay,
Ah.
okay. Because the I think it's from clinical perspective, it's one of its kind, because generally we don't have standards for or
Yes, yes.
disease specific. This is something very unique in that sense.
Fantastic. That is what I want to say, Dr. Suvin,
Yeah.
that these are the first type of standards which have developed for the disease specific. And Indian Stroke Association was looking, our past president and president, they were looking for developing a uniform. See, we all, as a clinician, I'm a stroke neurologist and treating stroke. Nationally, all our stroke neurologists were treating stroke, but we try to develop a uniform standards. We want that nationally people get a uniformity and some benchmarks for the clinical quality outcome. And that how I think I've been taught. I was also part of that assessor program, and I've been taught by QA. Dr. Rana has taught us to read this standard. I was part of making this standard, but I learned a lot. And when my hospital was got assessed, I tell you, my whole team, and I think Dr. Gracie also mentioned that we have gone a lot of churning of developing and improving our own setup, which we were thinking that we are doing very good. When you're analyzing alone without any clinical quality indicators, I think it made a huge difference for all of us across India.
Yeah, may I have one here? Kumaravelu here.
Yeah, Dr. Kumar Velu, good evening.
Yeah, good evening. Good evening, Arvind. Yeah, we also got accredited this thing, and I was part of the accreditation team. I'm one of the assessors also. What is important is that the thing that which we got through during the assessment is that we streamlined, and one more thing is the recognition that needs to be conveyed to the public. See what happened the other day. One patient went to a hospital treated by a physician. I'm not denigrating any trade by saying this thing, but what was said and done, a stroke neurologist any day will know better to manage an acute stroke than a non-stroke medical person. That we'll have to accept, and then this getting this recognition and spreading the awareness to the public that this particular setup, I'm not saying that my hospital or any hospital for that matter is likely to benefit by getting the accreditation, so that the public will know, yes, you go to this place, they will have standards in place and they will be able to treat you appropriately as per available international standards.
So may I add to it, Dr. Shetty, what
Yes,
Dr. Kumar Velu had made a wonderful point, right? Once is the internal audit and internal assessment, which is done for your hospital. But after you get accredited, any accreditation body like the QA has accredited one hospital, right? Or NABH has accredited one hospital. So we used to see that this is a QA accredited or NABH or any accreditation body or JCI accredited hospital. It makes a huge impact for the patient and belief, and a lot of tie-ups with the other bodies, the corporations, like which you do when you say that you are stroke accredited body and your hospital is stroke accredited. Like long back, I was discussing, Dr. Rana is here, and he will agree that JCI was the first body where the first accreditation happened in Hyderabad for stroke, right? But there were no standards in India. So it was a wonderful thing happened that when we had a first meeting with Dr. Rana in QAI, and we got to know that the America and Canada, these are the two only bodies where the disease specific stroke standards are there. And why don't we were having a talk with the AHA, American Heart Association and American Stroke Association. He told that why don't you have a Indian standards which are for disease specific, but we cannot do alone. He told we need a Indian Stroke Association support, and we were looking for that. So we grabbed that opportunity, and now we feel that this is the best thing happening for our Indian Stroke Association.
It's amazing, sir. This story of a professional body like Indian Stroke Association joining hands with the accrediting body and coming out with the Indian specific standard is one of its kind, sir. All great collaboration. I mean, the teamwork from both sides definitely deserves applause.
And on par with the international standards, that's more important.
Yeah.
standards are on par with international standards. Maybe slightly stiffer than what AHA guides.
Yeah.
I told this to Rana in one of the meetings earlier.
And that is why the Asia Pacific Stroke Congress has asked for have a presentation there. Next week, I'm going to present our standards there. Yeah.
Fantastic. So thanks, sir. Thanks for the inputs. And I think we'll proceed